today I have been asked by the organizers to talk to you about observational studies, and after Dr. Stockless talk on how interventional or experimental studies are planned, this would turn out to be a bit of a bummer for most of you people, but you should know that most of you are actually going to do observational studies. So when we talk about clinical study designs, we can divide them into two broad categories, those which are descriptive and those which are analytical. The analytical ones want to come up with some inference of some sort, while the descriptive ones just want to tell what is exactly happening. Descriptive studies include surveys, case reports, and case series. Analytical studies, which are observational, are broadly of two types, but there are several other types also which are not commonly used in clinical research. The two ones which are used in clinical research most commonly are case control studies and cohort study, which we will be focusing on today. Now, whenever we are talking about observational studies, it is important to remember that the unit of observation is the person or the patient. And based upon in which direction you are studying, the studies can be called as prospective if they are looking in the future, and retrospective if they are looking in the past. So this is a simplified diagram to understand how these studies are called. A cross-sectional study is basically a cross-section of the population, which is looking at population at a particular time and place. A prospective cohort study starts with a cohort, follows them up over the future, and sees them as they go on and evolve the condition of interest. A retrospective cohort study starts with a population and tries to go back in the past and finds out what exactly happened to them. A case control study also starts with cases and controls in the present and then goes back to the past to find out what was the reason they developed that exposure. Now, there are two broad components for any observational study that you are actually interested in. First is exposure. What is exposure? Exposure is basically the factor of interest which influences the outcome, and these may include things like prognostic factors, these may include things like treatment which you have delivered, and may even be the results of your diagnostic tests. Outcomes are the result of interest, which is typically in most clinical studies would be the occurrence of a disease, say cancer, or death, or toxicity. In certain observational studies, particularly where these outcomes may be rare or may occur after a long period of time, you would want to use measures which are surrogate measures. Let's start off with case control studies. Now, case control studies, they start out by identifying the subjects by the outcome. What does that mean? It means that you identify subjects who have the disease of interest. Say you are studying lung cancer, you will start out by identifying cases of lung cancer, and you will identify controls. These will be subjects who do not have lung cancer but will typically come from the same source population. Now, why we do case control studies? Basically, if there is an association between a disease and a postulated risk factor. Where is this useful is when you have a disease which is uncommon or evolves over a long period of time. So you do not have the resources and the time to actually study this disease prospectively. This is a hypothesis to tell you what exactly a case control study looks at. So the hypothesis goes like this: because of the rarity, very little is known about the etiology of malignant germ cell tumors. So the key word over here is etiology. You are not really looking at whether how commonly malignant germ cell tumors are occurring in the population. To explore risk factors for these malignancies and generate etiological hypotheses, so this is very, very important. Please remember that observational studies like case control studies do not allow you to attribute causation to the risk factor. What does causation mean? So when you do a case control study, you will come up with a variety of risk factors. Say this can be things like undescended testis, This may be things like smoking in the mother, this may be things like the birth weight and so on. Now, these risk factors may or may not be associated with an increased risk of development of germ cell tumors. But even if you have a very high risk, it doesn't matter how strong the odds ratio is, it does not allow you to tell that this causes a germ cell tumor. This is a very, very important point to keep in mind. So to generate this etiological hypothesis, the authors want to conduct a population-based case control study. The keyword population-based is important because it tells you where the controls are going to come from. Of 105 children who have been diagnosed with malignant germ cell tumors and 639 controls who should not be having germ cell tumors. And why it is important to understand this is that case control studies, although are simple, elegant to perform, but they are subject to serious bias. And the most important bias that they are subject to is selection bias. So bias, that is selection bias, is occurring because the probability of including the cases or controls is associated with exposure. What does this mean actually? Suppose you want to do a case control study whereby you want to select a group of patients who have lung cancer and you want to see how much does smoking increase the risk of developing a lung cancer. You choose your cases as a lung cancer and you go to the chest ward to find out people who do not have lung cancer and you pick up patients with COPD. Now, of course, you have to understand that the risk of developing COPD itself is associated with smoking, and therefore there is a risk of selection bias occurring. The next important thing or important source of bias, and this is true for all retrospective studies, is known as information bias. What is information bias? It is basically systematic differences because of completeness or accuracy of data. So, for example, people who have lung cancer may attribute this to their having had more alcohol. On the other hand, people with COPD may not do so. So, you may have a higher chance of finding out that patients of lung cancer smoked versus patients of COPD did not, and vice versa also. There are various types of methods by which information bias can creep into the study. This can be in the form of interviewer bias also. The person who is actually going to take an interview is an important source of bias because it's a human. There can be recall bias, and finally there can be intervention bias. Means what is the type of intervention you have done. For example, in a patient of lung cancer, you maybe have been doing a high risk population, you have been doing say screening CT scans. On the other hand, in another control population, you have not been doing control CT scans, so you would not pick up those lung cancer cases anyway. Now, a case control study starts with identifying the population of interest. It goes on to then define the cases. You have to define this very precisely. Then define the controls and then measure the exposure. Please remember that the purpose of the case control study is to find out whether this exposure is associated with this case. So first is identification of cases. The first important thing is that cases should have the condition, and therefore a case definition is essential. Just stating that a patient with lung cancer will be taken is probably not enough, because you may have patients of lung cancer who have never had a pathological diagnosis because the lesion was quite small or patient was quite sick. So what exactly would be your case needs to be defined. Typically, for cancer cases, these would include histopathologically demonstrated cancers of a particular type. The next important thing is that we should not forget the temporal part of time-dependent endpoints. What does this mean? There are several endpoints in a case definition which are dependent upon the time. For example, stage. Stage at presentation depends upon how long the patient has waited for you to come for your checkup and things like that. And therefore, when you have a time dependency in your case definition, say for example, you are choosing stage 3 lung cancers. you automatically have an implicit assumption of the time in that. Cases should be representative of the population, and this is a very important point that you have to keep in mind. Please remember that the moment you start out with a hospital cohort, even if it is a cohort of patients who have been in a hospital which is catering to a large patient population, you still cannot assume representativeness. The act of coming to the hospital itself makes the person different from another person who may not decide to have come to the hospital. You should always remember that the cases will recall a greater amount of information when they have the condition. And the choice of case definition is based upon validity. What does this mean? It means that this is a case definition that has been utilized in similar studies in the past. It is a reliable case definition in the sense that any number of people can be accounted for by this case definition. So if you say a pathologically proven non-small cell lung cancer is something that would be considered as a valid case definition. Stating lung cancer itself is not valid because a small cell lung cancer, for example, can also be a lung cancer. The next important thing to remember is that whether you are taking incident or prevalent cases. Now, what does this mean? Incident cases are basically cases which have been newly diagnosed. Prevalent cases are cases which have been diagnosed sometime in the past, are undergoing various types of treatment, or are under follow-up. Now, why is it important to take incident cases? Because prevalent cases by themselves have an implicit assumption of survival. Whenever you are taking prevalent cases, it means that they have survived for a given duration of time in order to become prevalent. Next is cases who have migrated or treated outside are not represented. Incident cases also have better recall. So, for example, if you are doing a case control study in lung cancer, you try to find out their smoking history 5 years ago, a newly diagnosed patient with lung cancer will probably recall it better than a patient who is on follow-up. And if the exposure is resulting in a worse outcome in the disease concerned, then prevalent case series underestimate the effect of exposure. What does this mean? Say, for example, you are doing a case control study where you want to find out the association between smoking and lung cancer. We know from several studies that smokers with lung cancer tend to have a worse prognosis as compared to non-smokers. So, if you want to take a prevalent case definition, what will happen is you will have an overrepresentation of cases who do not smoke because smokers will die off early. So these are the reasons why it is important to have incident cases rather than prevalent cases. Prevalent cases are better when we do not have a clear idea about the date of onset of the disease. Typically, this is not the situation for cancer studies. The next important question is where should you select the cases from? You can do it from a population based, hospital based. You can do it from multiple hospitals. Population based case selection is of course better, but has the difficulty that finding cases unless and until you have a strong registry system. Population based cases in many countries will often receive variable treatment, and this also impairs case selection. And finally, it is difficult to ascertain the date of onset. The next important problem that you come across is identification of controls. Now, controls should ideally be drawn from the same population, but unless and until you define the population properly, this is a very difficult task. Proper identification of controls is essential to avoid selection bias, as we just dealt with earlier. Controls will often have poorer recall regarding the exposure, and therefore sometimes a nested case control study is usually done. So what is a nested case control study? A nested case control study is a small proportion of controls are compared to the incident cases and uses matching to control for common factors like age and gender. Now, this is efficient when exposure or risk factor is expensive to measure. What does expensive to measure mean? If you are using an assessment of whether the patient smokes or not, to understand this reliably, you can either do an interview based questionnaire, or you can also find out from an inexpensive urine test like the cotinine assessment, which is often done for your insurance purposes, as to find out whether the patient is truly exposed to tobacco or not. Now, if on the other hand, you are looking at a much more expensive test to determine the exposure instead of relying on a simple questionnaire, or your questionnaire is extremely complicated, time consuming, then what happens is that measuring the exposure becomes expensive. And when you have a rare outcome, which means your cases will be few, your expensiveness of measurement of the exposure is high, what will happen is that if you try to do a very large case control study, you will come up with situations that you will be using these measures in a large number of patients where you will not get the correct exposure. And therefore, these nested case control studies are often done to investigate the effect of things like gene polymorphisms. So you'll have a cohort in which you will have a nested case control study. What are the sources of controls? In nested case control study, as I mentioned, it is from the cohort. In population-based studies, controls need to be selected randomly, and therefore proper random sampling is required. This is extremely important. Please remember that whenever you are doing sampling, it is extremely important that the sampling frame is determined. What does this mean? What is a sampling frame? Sampling frame is basically, how should I put it? It's a registry or collection of information about the individuals which are available for your sample. So whenever you are defining a sampling frame, you must have the individuals inside that frame. You must also have an idea about the number of individuals in that frame. So when you are doing a proper random sampling, you will have a sampling frame. A good example is, for example, you want to determine the exposure of oral contraceptives with breast cancer in females, of course. A good sampling frame may be women who have driver's license and have consented to give their health information. Now, why is this important? It is important because number of women who have driver's license is actually defined. It is also good because you have a patient population which has given a consent for identifying their health information, and you also have a way of record linkage from the driver's license to find out how many of them were cases and how many of them were controls. Of course, there is a bias. What is the bias? That women who have a driver's license would, by definition, belong to a slightly different socioeconomic strata as compared to women who do not have a license. Now, this example of women having license being used as sampling frame has actually been used in Western countries for doing case control studies. So this is not something that is out of my mind. Now, definition of absence of disease is absolutely crucial. If you are doing things like case control studies in breast cancer, you have to remember that definition of your control means somebody who is free of cancer, means that you must have a proper way of determining that this patient does not have an early breast cancer or a ductal carcinoma in situ. And the only way to do that would be to do a proper clinical examination, integrate a mammogram in that. So as you can understand, as this problem evolves, the expense evolves. The catchment area needs to be same as that of the cases, because otherwise there are many geographic and ecological confounding variables that influence the outcome. Of course, you must have disparate limitation of disparity in access to healthcare resource also. And healthy participants are often disinclined to participate. And this is an important source of participation bias in case of case control studies. One special note about hospital-based controls, because many of us are clinicians and will be doing case control studies which include hospital-based controls. One thing important to remember is that hospital-based controls are easier to
No, don't.
obtain,
Normal. I'll be.
but suffer from selection bias and may not represent a population due to referral and case selection. Controls may also share the risk factor as cases, as I had just explained about patients with COPD and lung cancer. Now, when you have selected your case definition, you have done your control definition, then comes the question of matching your controls. Now, some factors are matched in most case control studies because it removes the effect of confounding. Now, what is confounding? Confounding is a problem that arises because a factor is independently associated with the outcome as well as the exposure. Take a look at this picture. Our cases are patients who have ovarian cancer, and we want to determine the association with oral contraceptive pills. One of the confounding variables that is actually very important is age. Age itself increases the risk of ovarian cancer. Older you are, higher your risk of developing an ovarian cancer. And age also is associated with use of oral contraceptive pills. So in this case, age becomes a confounding factor. Now, this is where matching comes into play. If you match the age of the controls with the cases, what happens is that you remove the influence that this confounding factor has. Now, one thing it is very, very important is that you should not match the exposure being investigated. The exposure being investigated here is oral contraceptive pills. So if you match your cases and controls with the use of oral contraceptive pills, you can never find out the influence of oral contraceptive pills on the risk of developing ovarian cancer. What are the types of matching that can be used? You can have individual case matching, which is basically one case to the other case. It is usually reliant on putting 2 or 3 variables like age, gender, and few other points. They of course require you to have a much larger pool of controls which are available. Frequency-based matching relies on matching of frequency of an observed value of a variable in a group. This is sufficient for most studies and requires a larger pool of control. So in case of frequency-based matching, you do not match an individual case to an individual control. You basically match the control group such that the age distribution, for example, is similar in both the case and the control. Measuring exposure is the next important and difficult thing because exposures are often difficult to measure objectively. Therefore, you need standardized data collection forms, and several types of bias can occur like observer bias, responder bias. Responder bias can be reduced by blinding the subject to the hypothesis, and observer bias can be reduced by blinding the observer to the hypothesis. So, blinding is not something that is only limited to the realm of studies which are randomized interventional studies. Even in observational studies, measuring the exposure can be done in a blinded fashion. The outcome that comes out of a case control study is odds ratio. Now, it is important to understand the concept of odds because most medical doctors are not familiar with this. Odds is the ratio of the probability of the event occurring to that of it not occurring. Now, take this table. Patients have received radiotherapy and no radiotherapy. Some of them have died and some of them are alive. This is of course a crude table. Out of 110 patients who received radiotherapy, 10 have died. So what is the risk of dying in the radiotherapy group? It is 10 divided by 110. What is the risk of not dying in the radiotherapy group? It is 10 by 110 subtracted from 1, because if you do not die, you are alive. Risk is the probability of the event occurring. So risk is the risk of dying in the group, which is basically 10 divided by 100. Now where does 110 come from? 10 plus 100. So this is very important to understand that odds is basically a ratio of a ratio. It is not a ratio. Why odds ratio? Odds ratios are important in case of case control studies because we have no idea about the distribution of the exposure, that is the risk factor in the control population. What does this mean? When you are doing a case control study, you have cases with a defined risk of exposure. Say, let's say it is a simple risk, say high blood pressure. Now, your control population, which you are sampling, may not have the actual same risk of having a high blood pressure as that of the general population to which you are extrapolating the result. As a result, telling the relative risk is not possible in case control studies. You have to define the odds ratio. So this is one of the very important reasons why odds ratios are used in case control studies. So what are the final limitations? We have selection bias, we have information bias. The temporal relationship between the exposure and the events are often difficult to establish. What does the temporal relationship mean? Means smoking is associated with lung cancer, but is smoking temporally related? Means is it occurring before lung cancer or after lung cancer? Is sometimes difficult to identify. Estimates for incidence cannot be obtained because, of course, you have the full cases. You cannot identify in the population what is the incidence. And this is therefore a difficult situation where your exposure is rare or difficult or expensive to study. Please remember, exposure is rare, not the condition or the outcome. Next, let's come to the next important design, cohort study. The word cohort itself basically means a group of people with defined characteristics who are followed up to determine the incidence to or mortality from a specific disease, causes of death, or some or the other outcome. Now, cohorts are the word cohort actually comes from the Roman military usage of this word, and basically it was a system which identified where each person would be fighting in the time of the battle. So they would have organized groups with names and labels, so you will know for sure where exactly a single person was fighting at a particular time in a battlefield. Now, coming to cohort study, what is important to understand is that in cohort study, you are not having the outcome of interest in the population. So what does it mean? You're basically having a group of people who you think may develop the disease in the future. And you are trying to find out whether a certain exposure will result in a change. So your cohort will have the exposure of interest, not the outcome of interest. Cohort studies can be general population based, and I think all of you have heard of the Framingham Heart Study. It was a very important cohort study which gave us a huge amount of insight on the biology and the pathology of cardiac diseases. Cohort studies in the general population based studies allow investigation of several outcomes at once. So once you have a defined cohort, you're no longer limited to cardiac disease. You can think of looking at depression, you can think at looking at Alzheimer's disease and so on. What is very important to understand is that the exposures that are being studied should be relatively common because your cohort is defined with respect to the exposure, which may be things like your treatment, which may be things like level of a biomarker, which may be things like their personal habits, which may be things like your gender and so on. Cohort studies can be done in special socioeconomic group. For example, DOL study on the risk of lung cancer or the incidence of lung cancer in registered medical physicians. And in high risk groups when the exposure is rare, for example, in studies related to occupational safety. In cohort study, there is a possibility of having a comparison group. two types of comparison groups are possible in cohort study. Internal cohort comparison, where the group is obtained from within the cohort itself and classified based upon the degree of exposure. An external cohort comparison can also be used when you do not have an idea about the gradation of the exposure. Please remember one thing, in cohort study, all patients in the cohort must have the exposure. So when you are doing a cohort study, you will start with all smokers. An internal cohort may have smokers who are light smokers, who smoke less than 1 or 2 cigarettes a day, heavy smokers who suppose smoke more than 1 or 2 packs a day, and so on. So that will be an internal smoker. If you are doing an external comparison group, then you have to find a cohort of non-smokers in order to determine the association between smoking and lung cancer. Now, selection bias can occur in the choice of a comparison group if the exposure risk in the control group is not well defined. The outcome data for the control group is missing. This is, of course, something that can happen during follow-up. Your outcome data in the control group may not be available. And other risk factors associated with disease may differ in comparison. For example, the healthy worker effect. What is the healthy worker effect? Whenever you're designing cohort studies in studies which are looking at defined populations in working population, what happens is that people who continue to work tend to be healthier than people who drop out in between. And this is known as the healthy worker effect, because your cohort of people who will not continue to work and therefore probably not get exposed to a certain occupational risk factor would tend to be unhealthier or different from the population who continues to work. Now, when to measure exposure? You have prospective cohort, where the cohort is defined and the exposure data is collected in the present time. We want to look at outcomes in the future. This is, of course, expensive and time consuming, but it is less susceptible to recall bias and allows you to establish a temporal relationship. A retrospective cohort relies on identification of a cohort where the exposure was done in the past using a reliable method. So what does this mean? For example, you are doing incidence of cancers in radiation workers. You can use data which is available with the Atomic Energy Regulatory Board to find out the personal dose measurements to define your cohort. Here, the data has been reliably recorded over a period of time by a regulatory agency using a method which is valid. And that's why you can do the same. So, important point about a retrospective cohort and a retrospective study is that retrospective cohort is a cohort which is defined based upon measurement of exposure, which may be things like radiation dose, which was done in the past using a reliable method. A prospective cohort is where your exposure is defined in the present, and you will continue to follow up that group over the future to find out whether they developed a condition of interest or not. Now, when you should measure the exposure, irrespective of the time of measurement, it is better to keep simple measurement methods rather than complex. And very important thing, unlike case control studies, confounders can be measured reliably in prospective designs. So that's why a prospective cohort study has a better scientific validity in establishing causation. This is what an usual design of a cohort study looks like, and what you get as an output from cohort study is relative risk. Let's not go into the formulas, but understand that relative risk is basically what? The risk of the disease or the outcome of interest associated with the factor of interest. Now, why is this possible that we can calculate the relative risk in cohort studies? Because remember, this population who is disease free, from which you are deriving the sample, who have the exposure of interest and unexposed to interest, are basically representing this population. And therefore, you can calculate the relative risk which is applicable to the population. So relative risk it means there is a twice the risk of disease if the factor is present. So relative risk is much easier to interpret than odds ratio. It must, of course, be interpreted in the context of the underlying risk. I think most of you will understand this. Relative risk is a proportion, not an absolute increase. And of course, it needs to be interpreted with an estimate of precision, which is typically the confidence intervals. So just to go back, a relative risk estimate of 1.2 with a 95% confidence interval of 1.1 to 1.3 versus a relative risk estimate of 1.4 with a 95% confidence interval ranging between zero point 0.9 to 1.9. Which of these two relative risk estimates will be more reliable? The first one, because it has got a narrow confidence interval and it has a consistent direction. In this case, the 95% confidence interval lower bound is 0.9. It means the factor may actually be protective. What are the limitations of cohort study? These are of course expensive and time consuming, especially if conducted prospectively. Exposure and diagnostic changes will often change and thereby changing your case definition. Information on exposure can influence the ascertainment of outcome. For example, if you are doing more rigorous smoking, rigorous assessment or screening in lung cancer, you may turn up with information bias, and finally, you will have problems with loss to follow. Next, let us take a look at retrospective chart reviews, which many of us will perform in the course of our careers. Why a retrospective chart review? Because we are basically looking at a rare disease or a rare outcome. Usually, we do not have the funds to find out what is the outcome. And basically, a retrospective chart review is useful to determine a hypothesis. It also allows you to get a quick idea of the sample size that you would require. And it's not scientific, but sometimes you need something for your promotion. The key aspects of a design for a retrospective study are that you need to start out with a protocol. Now, it is extremely important to understand that a protocol is not only important for a prospective randomized trial, but it is also important for a retrospective study, particularly because you have to define what your sampling frame will be, what your sampling technique will be, what are the key outcomes and exposures you will measure, and finally, it should define your case record form. Please do not start data collection without thinking about what you are planning to write, and we will have a class on how data collection instruments are supposed to be designed. Ideally, you should formulate a statistical analysis plan also. So what all these things are meaning is that a retrospective case study is not starting with data collection. It is starting with designing of the study, having a clear understanding of what exactly do you want from the study before jumping into looking at the case records. Finally, please remember that whatever findings you get from a retrospective case series, you have no idea of the causative point. There is a last group of studies which are known as comparative effectiveness studies. Archie Cochrane, who was a very famous clinical epidemiologist, and most of you would have heard his name, defined two concepts related to assessment of healthcare interventions. Efficacy is the extent to which an intervention does more good than harm under ideal circumstances. This is typically judged using data coming from randomized controlled trial. Effectiveness, on the other hand, assesses whether the intervention does more good than harm when provided under usual circumstances of healthcare practice. Therefore, it's often known as real world data analysis. So, comparative effectiveness studies are types of observational studies which utilize the available healthcare data to compare the effectiveness of different interventions in a population. This data is typically obtained from national, state, or regional registries or from coalitions of research groups. Please remember that your hospital data does not allow you to get a comparative effectiveness study done efficiently. You can do it, but not efficiently. Generates evidence regarding the effectiveness in the general population, whether the intervention works in subpopulations or rare conditions. Compare the effect of different healthcare delivery settings. And finally, it also provides longitudinal information on costs and resource utilization, especially when it is linked to reimbursement. Word about restriction and matching. These are terms that you will come across when you are designing observational studies. Restriction basically means the use of inclusion or exclusion criteria to define a similar set of individuals. So this is basically a method of reducing selection bias and allows or prevents variation in the level of known confounding factors. Matching refers to linking individuals with similar characteristics in the group. So matching is not selecting people based upon inclusion and exclusion criteria, but matching them based upon their characteristics. In case of cohort studies, you can use propensity score based matching techniques. What are these? These use usually a logistic regression technique to generate a single propensity score based upon the various observed exposure values. And from there, you found out a matching score for each of the two groups. To conclude, observational studies are crucial components in the evidence chain. Many of you will be conducting observational studies far more than what you will be conducting interventional studies. And therefore, a clear-cut idea about how to design these studies in a scientific manner is extremely important. These are important for effectiveness research, hypothesis generation, and also for causality estimation. Therapy efficacy, however, needs careful RCT. So this is something that I would like to emphasize once more. To determine the efficacy of a therapy, you need to have randomized controlled trials. You cannot do it on basis of observational studies. The design of observational studies is actually quite complicated because you have to account for bias and confounding. And for those of you who are interested, Dr. Vijay had introduced the Equator Network to all of you. I would go back, I will tell you to recommend, and I will tell you to go to the Equator Network and look at the stroke guidelines to understand how observational studies should be reported. Finally, I would like to end by thanking all my colleagues and friends at my center who have allowed me to give you this much amount of time while taking care of my patient care duties. Thank you.